Good afternoon, everyone. I am going to present case number 2. History provided was 45-year female. She visited surgery OPD with gradually increasing mass over left sole for 2 years. She underwent punch biopsy, eventually followed by below-knee amputation for complete histological assessment. Plain X-ray radiograph revealed a soft tissue opacity in the subcutaneous plane, infiltrating into the deeper tissue. However, the underlying bone was not involved. This is a gross photograph showing the large cauliflower-like mass, approximately 10 into 10 into 4 centimeter. On cut section, it was nodular, glistening, gelatinous, fleshy in appearance, and firm in consistency. There were also foci of hemorrhage were noted, but there was no areas of necrosis. One scan slide was circulated. I would like to invite representative from Divya Patil Medical College to discuss this case.
Okay, so in this slide, what we can see is there is a tumor which is appearing infiltrated in nature, and there are solid sheets. There's a nodular cystic kind of appearance. That is all I can say on this. And there are some myxoid kind of areas. Again, there are these islands that are seen, which are having cribriform kind of a pattern. There are glands that are seen. There is a myxoid appearance that is present. The next slide. Here there are few tiny clusters of 2 to 3 cells and single cell that is seen infiltrating into the stroma as well. Here again we can see a cribriform pattern. We can see few glands. The cells are round to polygonal. They are having a high N by C ratio, a vesicular nuclei, prominent nucleoli, and a eosinophilic cytoplasm. The mitosis is not very brisk. It is infrequent, though few atypical mitoses are seen. So in the slide that we had received, so there was the epidermis which looked unremarkable, and this was basically a dermal based tumor which was having a ill-defined border. It was infiltrative, and we had these nodulocystic areas. We had glands. We had solid pattern. We have cryptiform pattern, plus clusters of 2 to 3 cell single cell infiltration. There was myxoid area that was seen. There was no necrosis. There was no pigment that was present. Uh, and the periphery of the tumor showed presence of this lymphoplasmacytic infiltrate. Few of the islands they showed like as if they had a basement membrane that was intact. So going by these features, we thought firstly that it's a malignant tumor since there was infiltration. Secondly, it was a primary cutaneous tumor since we saw that basement membrane like areas. In addition, there was a lymphoplasmacytic infiltrate in the periphery. Uh, and we thought it might be a appendiceal tumor uh, because the overlying epidermis was normal. So later, then we put some IHCs, like we put a GCDFP15 for a sweat gland tumor. We had put P63 to highlight the basement membrane. We had put a CK7, and we had put synaptophysin and androgen receptor, but all of the tissue other than CK7, the tissue got washed off, so we couldn't interpret. But CK7 was positive in the glands. So those a few glands were CK7 positive. So looking at that myxoid background and the DDs we thought of firstly was a primary cutaneous mucinous carcinoma. So we have a pure type in which there's more than 90% of mucin, and there is a mixed type where there's less than 90% of mucin. So we thought maybe a mixed type of primary cutaneous mucinous carcinoma. We thought of endocrine mucin producing sweat gland carcinoma. So in that case, a synaptophysin would come positive, but we couldn't do that IHC because it got washed out. But it is anyways considered to be a precursor of primary cutaneous mucinous carcinoma, and it's in WHO it's mentioned that even if it's a endocrine carcinoma, but if there is areas of infiltration and there is presence of mucin pools, we should give it out as a mucinous carcinoma. Then, since there were cribriform areas and the site was sold, we thought of cribriform apocrine carcinoma, but we didn't see the apical snouting. We even thought of maybe a mucoepidermoid carcinoma, but WHO calls it as hydroadenocarcinoma. But the atypia was not that. There's not. It didn't look very aggressive, nor was the mitosis a lot, nor did we see those different types of cells. And we also thought of a myeloepithelial carcinoma. So since we didn't have a ISC which we could interpret as such, so we thought basically maybe more of a primary cutaneous mucinous carcinoma mixed type, or maybe a myoepithelial carcinoma.
Okay. Thank you, Divya. You have described the case very nicely. Any other opinion from house? I will be highlighting few important feature of the case. She was 45-year female with a lower extremity mass, and the tumor was located in the subcutaneous plane and it was infiltrating a margin. However, the tumor cells are arranged in a multinodular pattern and also in a trabeculae as well as in cord against abundant myxostroma. At places that glandular arrangement, the ductular component is also seen, and the individual cell morphology was epithelioid type with vesicular nuclei and prominent nucleoli. There were 5 to 6 mitosis identified per 10 high power field, but there was no areas of hemorrhage and necrosis identified on a multiple section examined. So on the basis of this histomorphology, we thought of following differential diagnosis. We thought of, first of all, myopithelial carcinoma. Then we thought of proximal type epithelioid sarcoma, poorly differentiated synovial sarcoma, malignant melanoma, epithelioid MPNST, and extraskeletal myxoid chondrosarcoma. So to narrow down our differential diagnosis, we try to narrow down our differential diagnosis on histology. So first of all, we rule out possibility of epithelioid MPNST as well as extraskeletal myxoid chondrosarcoma. In both these tumor can occur on the lower extremities. It shows more architectural as well as cytological uniformity, which is in contrast to our tumor. Then, in view of epithelioid morphology and prominent nucleoli, we thought of malignant melanoma, but myxoid stroma is very rarely seen in malignant melanoma. So we rule out possibility of malignant melanoma also. Then, in proximal type epithelioid sarcoma as well as poorly differentiated synovial sarcoma, in addition to whatever feature I have described, it will, in addition to show breast mitosis, necrosis, and characteristic hemangiopericytoma like vasculature in synovial sarcoma, as well as rhabdoid morphology, which is characteristic of epithelioid sarcoma. Then in myopithelial carcinoma, you will get the architectural as well as the cytological heterogeneity, abundant myxoid stroma, epithelioid morphology with a prominent nucleoli. So most of the feature were going in favor of myopithelial carcinoma. So we ran few markers to confirm and to rule out the other differential diagnosis. So we did cytokeratin 7, which showed diffuse and strong positivity throughout the lesion. Then we did pancytokeratin, which again showed strong cytoplasmic positivity. Then we did ascended protein, which showed which showed positive nuclear positivity throughout the lesion. Then we found loss of expression of INI1 throughout the lesion, and P63 was non-contributory. This is Summarizing the IC marker. So cytokeratin positivity as well as pan-cytokeratin positivity rule out the possibility of epithelioid MPNST, then extraskeletal myxoid chondrosarcoma as well as malignant melanoma. Then strong positivity of ascended protein rule out the possibility of epithelioid sarcoma as well as poorly differentiated synovial sarcoma, which shows focal positivity for the ascended protein. Then most in myopathic carcinoma, the ascended protein is strongly positive. Then we did INI1. In most of the myopathic carcinoma, 40% of the cases will show loss of INI1. Then we did P63, which was non-contributory in our case, and it didn't help in our diagnosis. So considering the histomorphology and the IC marker, we rendered the diagnosis of myopathic carcinoma over rest of the differential diagnosis. Two important words about the myopathic carcinoma. Myopathic carcinoma has put under the myopathic tumor category of uncertain histogenesis under WHO recent addition. It has a broad anatomical location. The most commonly, this tumor can occur on the lower extremities. However, the proximal extremities are uh, followed by the proximal extremities. However, the rare locations are head and neck, then the bone and the visceral organs. These tumors show morphological as well as immunophenotypical similarity to their counterpart in the salivary gland. And most of the lesion, that is myopathic carcinoma, will show EWS RNA1 gene rearrangement. And the most common gene partner associated with these tumors are POU5F1, PBX1, ZNF44, and many others. Due to cytological and architectural heterogeneity, diagnosing this tumor can be challenging only on the basis of histomorphology. And if you are unfamiliar with this entity, it can lead to erroneous diagnosis and the fatal outcome. So the take-home message in this case is, if you come across the mass over the lower extremity with a varied histomorphology, epithelioid tumor cells, and abundant myxoid stroma, you should always keep myopathic carcinoma in your differential diagnosis. Thank you.